on a time, and all the speaker who come here, I think when they speak, they tell about themselves what they are. So I mean, please excuse if somebody is feeling I have not kept chairperson.
So again, I'm repeating, I'm a Dr. Y.P. Singh. I'm working as a head of department critical care at Max Super Specialty Hospital, Patparganj. So Max Corporate is having 12 hospitals. 3 super specialty hospitals are already in Delhi. I am working on a PPG which is on the east side of the Delhi, near to the Anand Vihar railway bus station. So this is my hospital. It is a 410 bed hospital. In any given point of time, 20-30 patients remain in waiting over and above the bed strength. It is going to be a 700 bed hospital in 2 years of time. Work is already going on. So this is my ICU. I'm primarily looking after the medical intensive care, and that has having a entire floor housing 29 beds with SDU, 2 SDUs with 4 beds with bone marrow transplant. And as a part of the protocol in a hospital, that all the patients, post-operative patients, after 48 hours, if they need a critical care support, we basically step in. So to begin with my topic, my topic is primarily, as you read here, is the acute disseminated encephalomyelitis. This is not something very common. Truly speaking, if you ask me, I am primarily a medical intensivist. I've been given this responsibility to speak on this topic. This is something not very, common, although also it is not very rare. Only thing is that you have to have a very high suspicion index whenever you are encountering these type of patients. So this is the overview of the topic. What it says that it's a rare inflammatory demyelinating disease of the central nervous system. An autoimmune disorder triggered by an environmental stimulus in a genetically susceptible patients, and more often triggered by the response to an infection or to a vaccination. And note, for this region, ADM is referred to as a, for subsequent talk, I'm going to use a terminology ADEM. You have to just correlate with that. Is referred to as a post-infection and post-immunization acute disseminated encephalomyelitis. I have been requested by the organizer and Dr. Rajesh Mishra to make a very colorful kind of the slides. So I also put in some kind of the spice by using too much of the animation. So kindly bear with me. So what is the definition of a ADEM? And the definition is basically, Michaeloff is given some more accurate and correct. He has defined ADEM is the occurrence in a previously healthy child of acute symptoms associated following at onset. Following is that more than one neurological deficit, post-symptomatic onset, changes in the mental state or encephalopathy, any alteration or lesion in the white matter on MRI. The lesion in the white matter of MRI is the most important part, which an audience has to understand to differentiate from the other pathologies when you are going to make your differential diagnosis. What is the epidemiology? So epidemiology it's the estimated incidence in the US is 0.4 per 1 lakh. Why every time we use a statistic of the US? Because we don't have our own. Probably in a time to come, Critical Care Society is working, in all breadth and length to have its own data. So maybe down the line 5 years, you are going to have your own data for most of the, critically ill components. So you need not to use those foreign data, which we are very often and very frequently we use in our presentations. So second is the more common in the children and adolescents. You have to understand the ADEM is more common in children. Maybe it's not the adolescent will not be get affected with this problem. They are. But primarily it will remain focused more on children, pediatric age group, that too less than 10 years. And the ratio is not that male females are equal. Seasonal, there you will find a seasonal variation, and these is part of the cases do occur in a winter and the spring. But they can also spread to any part of the year. What is the causes? And so they are primarily divided into 2 heads. First is the post-infection causes, and the post-infection causes contributes to 50% to 75%. And primarily it's the viral, as you are seeing on your screen. Can be caused by measles, mumps, rubella, varicella zoster, Epstein-Barr virus, CMV, herpes simplex, hepatitis, and influenza. And the bacterial, most important, it's the group A streptococcus bacteria can also. It's a basically autoimmune kind of the disorder where the body, misinterprets its own healthy tissue and start, working against that. Same mechanism works in this disease. And the second is the post-immunization. The total number of the cases which occur, ADM cases, after post-immunization is less than 5%. And the most common vaccination which is made a responsible, it's the MMR, measles, mumps and rubella vaccines, triple vaccines we call it. That's having a maximum occurrence with the ADEM. Signs and symptoms, how it basically presents, where you have to suspect. After the infection, after a week so time, if your patient is presenting with the encephalopathy, maybe altered sensorium, change in a sensorium, or sometimes patients do go into the coma, you have to have a high suspicion index. And diagnosed, and most of the time it is diagnosed as a viral encephalopathy. You have to have that kind of a suspicion. And the most common symptoms you are seeing on your screen is the headache, vomiting, drowsiness, meningitis, and the seizures. And the seizures contribute to 13 to 35% of the patient, not in all patients. So it's primarily the encephalopathy where you have to focus on. When the patient had a child is presenting with an infection, 1 week or so after having a CNS involvement, you have to have a high suspicion index of a ADEM. What are the signs? The common neurological signs are here. It's a cranial neuropathies. The most common is your optic neuritis. And the optic neuritis is, I'm going to discuss it with the, you have to having a differential diagnosis with the multiple sclerosis, which do occur in this age group of the patient, and how you are going to segregate between the two, because optic neuritis is a bilateral in an ADEM, while it is on a unilateral in a multiple sclerosis. Next is it can be involvement of your pyramidal tracts, hemiparesis, cerebral ataxia, when the patient is presenting with a decreased muscle coordination. What is the diagnosis? How you are going to make a diagnosis of this rare, not so very common kind of a entity? It says that it's a multifocal neurological abnormalities with evidence of encephalopathy, as I mentioned previously, especially if the onset of symptoms occurs within 1 to 2 weeks after a viral or bacterial infection or vaccination. So if your patient is presenting post-infection 1 to 2 weeks or after the vaccination, you have to have the high suspicion index presenting with the encephalopathy. You have to keep these two possibilities in your mind and keep on investigating the patient till you reach to your conclusion. So it must to rule out the primary CNS infection. The only thing is that whenever you are concluding these autoimmune kind of the problem, you have to rule out the other CNS infection. They should not be. If it is an infection, you have to treat that. Because not always you are going to get an ADM. It's not that common. Investigations. What are those investigations? If you'll go for the routine blood investigation, you will simply file a leukocytosis, increased ESR and lymphopenia. They most or less you will find in most of the pathologies, it's a more inflammatory response of the body. If you'll go for the CSF or lumbar puncture, you will find a pleocytosis, increased protein count, intrathecal synthesis of oligoclonal bands. They are not very common. The difference between the multiple sclerosis and ADEM is that this is oligoclonal bands are found in a multiple sclerosis, which is not be there. Even if you'll find it is hardly in a very low number, that's a 0 to 29% of the cases. But if you will compare the two, definitely oligoclonal bands will be found with the or associated with the multiple sclerosis, not with ADEM. So next is your radiological imaging to supplement your diagnosis or to support that. MRI criteria. So if you'll go the MRI criteria, they are very specific, and here is the, what it says. In ADEM, you will find a multifocal lesions of less than 5 centimeters. They are a large size, not well-defined lesions, which differentiate from the multiple sclerosis from the ADEM. There are a confluent multifocal lesion of more than 5 centimeters, multifocal lesion involving basal ganglia. Primarily side which is a basal ganglia is more often involved in an ADEM than in a multiple sclerosis, and lesions are deeper in a white matter. You have to see that if the white matter has to be primarily involved in an ADEM, not in a multiple sclerosis, and with periventricular sparing which is found in 29 to 60% of the cases. I try to make my presentation more and more simple for the audience, so when they will go back, they have to have some idea regarding this pathology. So the lesions are typically large in brainstem and spinal cord. If you're seeing in a spinal cord, definitely they are large enough. And that's basically one of the differentiating points. They are more of in a thoracic region in a ADEM, while in a multiple sclerosis you will find more in a cervical region, these lesions. So multiple lesions with poorly defined margins in a deep and subcortical white matters are common, and the characteristic of demyelination in ADEM. This is basically a pathognomonic where you have to have understand that how you are going to make a difference with the multiple sclerosis. And I have taken a few, 2 slides involving the MRI findings, as you're seeing here. This is a basal ganglia area with a 2-year-old previously healthy girl developed the post-infection focal encephalitis. And on MRI, they found these findings, and on the left hemisphere also. So these are the findings. Next, again, a 7-year-old previously healthy girl developed post-infection focal encephalitis, and here you are seeing the both, basal ganglia area is involved, where you are seeing with the red color of a, marker. So this is how you are going to make your conclusion or diagnosis. And the other diagnostic criteria are, the major criteria, what this says in making a diagnosis of ADM is, a first clinical attack of CNS demyelination disease with acute or subacute onset. It's a polysymptomatic, where you will find a monosymptomatic, the difference between, I'm going to discuss that. And these criteria are basically, as you see on the down on your slide, it's given by the International Pediatric Multiple Sclerosis Study Group. So based on that, they made a major criteria. First is the first clinical attack on a CNS demyelinating disease with acute or subacute onset, polysymptomatic neurological feature with encephalopathy. Next, a brain MRI shows focal or multifocal lesion predominantly involving the white matter, as I mentioned, without evidence of previous white matter changes. Then how you are having, you are dealing with the ADEM. Next is your encephalopathy, as I mentioned earlier, as a presenting symptom, with the onset of encephalopathy corresponding with the occurrence of the disease state. These are the different types of the ADEM you will be. It's a monophasic, recurrent, or a multiphasic. A monophasic, obviously, when you are having a one attack, that too, patient can present as long as 3 months. A recurrent, when you are having a recurrence and same symptoms that occur during the initial attack. And multiphasic ADM is defined as the attack that involves new area of the central nervous system from the initial or previous attacks. There must be a sign of encephalopathy. Again and again, they are focusing on this clinical feature. You have to have that suspicion, and then you have to move in that direction to fix your diagnosis. So 3 types. And here I have taken a comparison between the two, how you are going to make a difference between the ADM. As you are seeing on your screen, that ADM is a monophasic. It occurs most of the time in less than 10 years, as I mentioned, in a pediatric age group. Female-male ratio is equal. It's a prior flu-like illness, and along with your encephalopathy. Seizures are that too not in a very high, up to 35% you will get, and course of the week is 3 weeks. If you will go for the CSF, as I already mentioned, you will find a leukocytosis, but there will not be oligoclonal bands there, IG bands. And if it is there, that is maximum up to the 29. So we don't consider it to be, it is more of a diagnosis for a multiple sclerosis. White matters are basically involved if you go for the MRI, and on pathology, you will have a more of the inflammatory feature than a demyelination. That's another a differential between the two. Coming to the multiple sclerosis, it's a monosymptomatic, occurs more in adolescents. Females are more than male, and again, oligoclonal IgG bands are there in a multiple sclerosis, which you won't find there. So the lesions you will find on an MRI, that will involve primarily the gray matter. And here the demyelination is more and inflammation is less, which on the contrary, the inflammation is more in the ADM and demyelination is less. This is how you are going. So basically primarily ADM is having a differential diagnosis with the multiple sclerosis. So whenever the patient is coming with the second attack, you have to see, based on your MRI, you will reach to the conclusion whether you are dealing with the ADEM or multiple sclerosis, because their outcome is entirely different, their course is different, and treatment more or so remain the same. So coming to the treatment part, it says that if you have made a diagnosis of the ADM down, you have to go for a pulse therapy with the methylprednisolone, that in the dose of 10 to 30 milligram per kilogram body weight, and dose has to going up to 1 gram for 3 days, followed by an oral steroid prednisolone for 6 weeks. So 6 weeks therapy with a 3 day of the pulse therapy. Next therapy is your PLEX. A plasma exchange is recommended if there is no response to the corticosteroids. And third is the immunoglobulin IVIG. It recommended is there if there is no response to the PLEX in the dose of 1 gram per kilogram per day IV for 2 days. So I've given a note in the down on the screen. You are seeing the first consider any patient coming with the encephalopathy. Obviously you have to rule out the infective pathology. You will start with the antibiotic. You will start with your antiviral therapy. And you can also add the corticosteroid at the same time. And most of the time you will find the neurologists, when they are coming and they are dealing with these patients, they already start with the antibacterial, antiviral, and they start with the steroids. So same thing is applied here. As I mentioned, before you reach to or before you move into that direction, rule out any infective pathology before you thinking about the ADEM. What is the strength of recommendation? Strength of recommendation is not that good for the PLEX. It's only in favor of the steroids. As you are seeing, it's having a moderate evidence, and for the IVIG, it's having a poor recommendation. You can use it, but it's not basically supported by any data or any evidence on that. Coming to the prognosis for most children with ADM is good. 60 to 90% are left with no neurological deficit. That's basically a differentiation between the ADEM and the multiple sclerosis. A recovery is usually a slow process lasting from 4 to 6 weeks. And should there be a relapse, either multiphasic ADM or multiple sclerosis should be considered. And based on the MRI, you can discriminate between the two. So you can prognosticate and you can move into that direction. So next time I'm going to change, take work message. So what's that? It's a post-infection and inflammatory encephalomyelitis. It's a usually monophasic with principal affects the brain and the spinal cord. ADM is predominantly disease of the children. Historically, it includes post-infection encephalomyelitis and post-vaccination encephalomyelitis. This disease is characterized by multifocal white matter lesions on neuroimaging or MRI. Thanks for your kind attention.
Again, very important topic, ADM, missed. And once you miss around just 24-48 hours, you are not able to diagnose in time. Patient has very, very debilitating course and they stay in hospital. And if you diagnose fast, patient gets better just within some 72 hours or so. It's such a big difference. And that's precisely that was the reason. Maybe you may say this case once in a year or twice in a year, but whenever you see and diagnose, it makes huge difference in somebody's life. That was precisely the reason to keep this topic. Any question, please, for ADM?
So again, I said there is a moderate, evidence in support of the plaques. Obviously, you have to first, as I mentioned earlier in treatment part, you have to start with the anti-infective treatment along with the steroids. And if you see that it's not working, obviously you have left with no other choice but to go for the other modality of the treatment.
What I do in my practice for ADM, if I get severe ADM, I start both together. High dose methylprednisolone and plasmapheresis or IV gamma, whatever patient can report. Most of the patient, because of the cost issue, I have done plasmapheresis 5 cycle plus 1 gram dose of the methylprednisolone for 5 days, and they have worked excellent. Luckily, maybe we are a little bit too proactive in diagnosing, so we are able to diagnose them early. Like one of the patients we got at 1 a.m. in morning, 3 a.m. we could diagnose thing with MRI, and 4 a.m. thing we started, and third day patient was walking.
But I would like to say one more thing, but you don't know whether it's the steroid are working or it's the plaques is working.
That's why I say both, we combine both, because there is very no clear-cut guideline, and both are not contraindicated, and that's why we combine both.
I'm taking the words of Dr. Rajesh Misra with respectfully, but I would like to say that I'm working in a kind of the environment where the evidence is the foremost, and most of your guys who are working with you in a team, they are going to kill you if you are not going to give your evidence-based treatment to the patient. I'm not saying that all the treatment has to be evidence-based, but definitely, primarily, is the outcome is the most important, but definitely. So whatever he said is absolutely right. You have to put on a full throttle, all the combination of the therapy, but it has to be on a evidence-based. Thank you very much for your patient listening.
Good morning, friends. Again, I'm back. This time, please keep your senses open towards the last summary of the talk, because I've made a poem myself on stroke and how you should manage stroke. So I really want to finish the topic fast so that my poem will convey what I want to convey in the entire lecture. So let's try and see what we can do in the next 15-20 minutes. Now, acute ischemic stroke is what I'm going to talk about, not stroke alone, and I will lay emphasis on the management with lysis and without lysis. We know that time is essence, we know that time is brain when I give a talk on stroke, we know that time is heart when I talk on cardiac arrest and other things, I know time is muscle, etc. But now I have to say that time is brain. And we should know that 85% to 87% of all strokes are ischemic in origin, and that's important. There are 3 types of stroke. You have an ischemic stroke, which is 85%. You have intracerebral hemorrhage, which is about 10%. You have subarachnoid hemorrhage, which is 5%. The first 2 actually join and form the focal brain deficits, and the other 2, that is 15%, form the diffuse brain dysfunction. And the treatment matters upon how well you can treat these patients in the first few hours, and after that, how you can prevent secondary brain injury. Whether it be head injury or whether it be stroke, it's extremely important for us to limit secondary brain injury later. Just a little physiology of acute ischemic stroke. We know that the cerebral blood flow is not very homogeneous in stroke. We know that there is an ischemic core where there is very, very poor cerebral blood flow, and around it we know that there is a penumbra where there is a reduced blood flow, but not completely gone. And therefore, obviously, the blood flow is different in both these areas, and it is the penumbra which you can limit by improving the cerebral blood flow there. The core has already been damaged like the MI in the muscle myocardium. And this is how it would look. You would have the core in the center, you would have the penumbra within the brain. If you reduce this penumbra to this, you would do well. And as I said, time is brain. How do you reduce this penumbra? You could avoid things like hypotension,